Good afternoon. I see lots of folks are joining kind of in rapid real time here, so I'm going to just pause for about 30 seconds longer and then we'll launch. Welcome, everyone. I am Brenda Metzler, a community and program support specialist with Let's Grow Kids, and I'm pleased to host another conversation with the Vermont Department of Health, a couple of Vermont pediatricians, and an epidemiologist, basically the rockstar health team that we have at our disposal. As always, we invite your questions at the time of registration, and you submitted many this month. I shared them with this team of experts, and they are here to address your questions, your concerns, and to bring accurate and current health information and guidance. As they begin, I'm going to ask that you please hold your live questions because I anticipate that many of them will be addressed as they talk with us. And because we have so much to cover in the next hour, I am just going to hand it right over to the nurses and docs to start to address us and to introduce themselves. Thanks for being with us today.
Thanks, Brenda. I think I'm going to start and then hand it over to the health department folks to answer some of the awesome questions that you've already submitted. I'm Becca Bell. I work in the pediatric intensive care unit at UVM Children's Hospital in Burlington, and I'm the president of the Vermont chapter of the American Academy of Pediatrics. And I really just wanted to take a moment to thank all of you and to recognize and appreciate what you have all done for our patients, our children, and their families throughout this entire pandemic. And we're in a very strange and weird and challenging and disruptive time. But I just wanted to take a second to reflect on where we've been, because I think that, when we're in the midst of this surge with lots of cases and lots of infection, it's easy to kind of lose sight of where we've been and how far we've come. So I was thinking the other day recently about what it was like in March of 2020, which is now we're coming up on 2 years. And I was remembering a case, actually one of the first patients that I admitted that we had to test for COVID because they had respiratory symptoms and COVID was here in Vermont. And that was back in the day where even our hospital tests were taking many days to come back. So I was admitting a patient to the hospital, a young child who, for reasons unrelated to their respiratory symptoms, which turned out to be RSV and not COVID. But because we had sent the test, we had to wear all our gear, and it was days before we could actually kind of remove some of that because we didn't know if the patient had COVID or not. In the meantime, though, the patient was having something really serious going on with them. Again, totally unrelated to infection, but something that had been a problem and getting worse over the previous few weeks. And when I talked to the family, and it was, the whole thing was very challenging. We had visitor restrictions. It was right as things were going into lockdown. And not both parents couldn't be there, the fans on in the room were wearing all this stuff. And I'm having a hard time really having this conversation, very serious conversation about something going on. And leading into the pandemic, those of us who work in pediatrics in the hospital were really reading all the reports from China and Italy and some in New York and other places that had been hit hard. We knew that children from that data, surprisingly, were not as affected in terms of needing to be hospitalized or getting very severe illness from COVID. And we were cautiously hopeful about that. They're not, New York's not seeing a ton of pediatric cases. China wasn't seeing a ton of pediatric cases. And, sort of surprised because kids get so sick from respiratory viruses. So we were thinking how could this not be bad for kids? And so anyway, back to this patient, I remember asking them when did you first notice this? And, the mother saying, it even still was sort of I don't really even see what you're talking about, but my childcare provider told me that they were worried. and that something wasn't right. And so they told me to take them to the pediatrician, and I did. And the pediatrician said, something's not right. And they sent them to us. And I remember at that point just feeling like actually sick because we were shutting everything down. Like everything was getting shut down. Schools, it was the day they were announcing they were closing schools. Many childcare programs shut down, although many also stayed open. But all I could think about was that this child was here because of the team, right? Like the child care providers, the pediatrician, the hospital team, working with the family, working with children, and picking up on stuff that's really important. This condition was very, very severe, and it was really important. And that's when I realized that this is going to be really bad for kids. This pandemic is going to be really bad for kids, but not in the way that we can quantify so easily, like in numbers like hospitalizations, but in all of this other stuff that's happening. And pediatricians, we've always been so busy. You all have always been so busy with all of the stuff that happens to kids and families all the time. And that's the other piece, is that we're coming up on 2 years. It's been a long time, and life has happened, to kids and to their families. And you have all like been there for that. And we, as pediatricians, we've seen that, and we appreciate it because 2 years is a long time, especially when we're talking about this age group that you all work with. You know, my kids are 4 and 6. This has been half of their life, and really, really important things have happened. And you all have been there with us, with these young people, with their families, and helping them through all that happens during this time period. That's all very important. So, and I also feel like, and Dr. Holmes will agree with me, that you all have been with us through like just all this changing guidance, like, right? Like, remember at the beginning where we were like, in the hospital too, we're like washing everything and we're not wearing masks. And then it's like, okay, I guess we're wearing masks now. Okay, I guess the guidance is changing again. And you've been there with us, like, all right, I guess we're doing something different, and just trying to figure it out together and just do the best that we can. So we're going to talk to you today a bit about this next step. This is another phase, and we're in it together. But I wanted to take a moment to acknowledge that, you know, for some people, these past 2 years have been all about COVID, and COVID has played a big part, but also we see all the work that you're doing in all the important ways you're helping and supporting kids through this, because this, you know, this is their life, and these are really important years. So thank you so much for being there for kids. And I'm going to turn it over, I think, to Katie next to present some new information.
Thank you, Becca. That was a really lovely story, and I think it really highlights how important early child care providers, how important they are in families' lives. And I'm Katie Leffel. I'm with the Maternal Child Health Division at the Department of Health. And I'm just going to start off talking a little bit about kind of setting the scene here. So first of all, we just want to take a few moments to acknowledge how difficult the past few weeks have been for all of us, right? Omicron hit quickly. We're all grappling with changes to guidance and information of introduction of new programs like Tests for Tots. And, you know, we've also received some feedback, just to get this out of the way, that the leftover Kits for Kids test kits distributed before the end of winter break would have been useful for childcare programs as well. A few providers had emailed in that and just saying, you know, can't change the decision made regarding those remaining Kits for Kids test kits, but we do hope that this Test for Tots rollout will help keep your program safe. There's a lot of material to get through in this next hour, so we want to make sure your questions are all answered as well, to the best of our abilities. So to set the agenda, first we're going to go over just a brief review of Omicron, the variant, and how it's different. We're going to go over some of the new isolation and quarantine guidance, and then we're going to do a brief review of Tests for Tots. And then lastly, we'll go through the questions from the field that were already given to us, and then answer any new questions. And if something isn't addressed in this hour, we will certainly follow up with you. And I just want to put another plug in. The information changes quickly. use our website, the Department of Health website, for up-to-date information. The Department of Health and the CDD have been working very closely together and updating guidance as needed. So your feedback is really important as well. So continue to get feedback from the field and let us know what's not working and what's working really well, because that does help inform our processes. And so I'm just going to begin with a little bit of level setting on Omicron. So we all have a sense of COVID fatigue, and the surge of Omicron has not helped, right? It's everywhere. It feels a little scary. Oh, actually, here's Molly back again. She had a computer issues. I'm gonna let her take over.
So sorry about that. I got a notification that my computer was restarting, so great timing. But as Katie said, we wanted to start just by talking a little bit about Omicron and how I think we're all so fatigued with COVID. And seeing it constantly in the news with Omicron has definitely not helped. It's everywhere. It can be really scary. And we just want to, reflect on the fact that we talk a lot about personal responsibility in the pandemic. And while it's true that we do have a sense of personal responsibility and should be following basic public health guidelines, we also need to acknowledge that it's impossible to expect to keep Omicron out of all programs. Testing positive for COVID right now is not a reflection on what people's behavior is. It's not a reflection on how safe they're being. It's a reflection on how contagious Omicron is. And it's nobody's fault when somebody gets COVID. And we really need to remember that and, stick together and help each other get through these times with Omicron. So like we said, Omicron can be very overwhelming, but we're also starting to learn and understand more about Omicron and its impact. So we wanted to share some of the information that we've learned about it. So we have found that Omicron is more infectious, but results in less severe illness. So that means we're seeing new cases have really high numbers, but the symptoms themselves are less impactful. And we're seeing that especially with fully vaccinated and boosted individuals. And that's true for children as well. Even though we're seeing more cases in children, we haven't been seeing a significant increase in severe illnesses with them. So that's good news. We've also learned with Omicron that the incubation period is shorter, meaning that someone with a new Omicron infection might be contagious as early as 1 to 2 days after exposure. And we've seen that they're infectious for a shorter period of time. So when you combine the shorter incubation and infectious period, that's why we're able to shorten the quarantine and isolation guidance. And we'll say this probably more times than you care to hear, but throughout the pandemic, basic public health measures are going to remain vital. So things like getting vaccinated and boosted when eligible, wearing high quality masks, staying home when sick or experiencing symptoms of COVID, getting tested if you have any symptoms, maybe a close contact, or have taken part in activities that could put you at risk, such as large gatherings or travel, washing your hands regularly, and getting your flu shot. And just again, reminding you, as the virus changes, our knowledge changes. So what we know today may change tomorrow. We are going to do our absolute best to keep you informed, but we just want to remind you that information does tend to change with this virus. And like Katie said, the Department of Health website is going to be where you find the most up-to-date information.
This next section, we're going to talk about the isolation and quarantine guidance changes. They're putting some slides up for you, which is basically what you'll see if you go to the Department of Health website and look up this webpage. I'm not going to go over the slides directly. I'm just going to instead highlight some of the changes that will impact you guys. So the main changes to isolation: if you test positive, you can get out of isolation after day 5 if you meet certain requirements that are listed on the slide. The rationale for this is that the infectious period, again, of Omicron is shorter. You should still wear a mask around others through day 10. Although they cannot mask, children under 2 can leave isolation after day 5 if they have no symptoms. 2 to 5-year-olds, I have a 5-year-old, I know what it's like. Do the best you can with masking. They may leave isolation after day 5 if the other requirements are met, even though they aren't necessarily masking consistently. The main changes to the quarantine: if you're a close contact and not fully protected. So I'm going to define fully protected. So not fully protected is not vaccinated and boosted when eligible for adults and not vaccinated for children. So these individuals can leave quarantine on day 5 if they meet the requirements as listed again on the slides for quarantine. So actually, next slide, actually, Ria. The rationale again behind this one is that the incubation period of Omicron is shorter. You should still wear a mask around others through day 10. 2 to 5-year-olds, again, do the best you can with masking, but they may leave quarantine on day 5 if the other requirements are met, even though they're not masking consistently necessarily. Children under 2 years old in quarantine can take a PCR test on day 5. They can leave quarantine once they have negative results. At this time, there's not an at-home option for testing for those under age 2. We're continuing to explore other options as we're available, but not being able to mask does not mean you have to quarantine or isolate for the entire 10 days. This is a recent change, so and it does not stop you from participating in Test for Tots. And also, I'm going to do a quick update on contact tracing. Currently, again, everything that we're telling you is what we know today, right? So things may change. Currently, it's most likely that you will not get a call from the Department of Health. Department of Health remains a resource if needed, but will not be calling to contact trace as they did earlier in the pandemic. Eventually, the plan is to return to the pre-COVID epidemiology guidance with parameters to notify the Department of Health with outbreaks. And you'll be notified when that happens. And I wondered, Allison, from the epidemiology, would like to just jump in a little bit and talk about some of the contact tracing changes. Allison?
Sure. Hi, thanks so much for having me. The contact tracing is going to change. We're going to pivot from information gathering to information providing. So right now we've been prioritizing calls 0 to 18, those over 65, English language learners, BIPOC communities. We are pivoting that we will call every case, all 2,000, yes, but we will have a much shorter conversation where we will not be asking them to provide us information. We will just be letting them know that they're positive, letting them know what our guidance is and where to find it, and asking them to contact their provider, their school or their childcare or their workplace, and how to notify their close contacts. So we won't be gathering information from them, but just providing them as a resource. This is a change that will begin this Sunday. And it really is a reflection of the current climate that we're in with Omicron. And it is in alignment with CDC, which says that our traditional way of contact tracing isn't effective when you're in this kind of surge. And hopefully this will provide better help, and hopefully it'll help you all who are getting a lot of questions on the ground, because we will actually be touching base with anyone who answers their phone. And so we will be able to take a lot of those guidance questions, not so much your childcare and school guidance, but for families wanting to know basic what to do. What does it mean for the other household members? So hopefully we can relieve a little of that burden by taking those questions when people answer the phone. Thanks so much.
All right, and so we're going to start talking a little bit about Test for Tots, providing a bit of an overview on that. Before we get into more of the details, we want to review a few important points. The first thing is just reviewing what Test for Tots is trying to achieve. So there's two main purposes, two main goals that we want. The first is we want to keep kids aged 2 to 5 in their childcare program. And the second is that we want to keep staff working and programs open. I know by saying we want kids aged 2 to 5 in their childcare program, it brings up the question of what about the kids under the age of 2? And the reason that they're not included in this is pretty simple. It's that the antigen tests that we use have not been approved for that age group. And so we really don't have a way to include them when it's with the current program. That being said, we want everyone to understand Test for Tots will not meet every provider's needs. It might not be appropriate for every single person. And we also want to acknowledge the fact that it cannot fully prevent the spread of COVID. We can't guarantee either of those things, but we want to focus again on what the goals are, keeping kids in the childcare program and keeping those programs open. This is one strategy that can be used, but it's not the only way to operate your program. It's a tool that can be used to keep your childcare functioning if it is appropriate and operational for your program. But participation is voluntary for both the childcare program as well as the individual families. Some program directors and some families may choose not to participate, and that's okay. A few more specifics about the program. So test kits can only be used for children and staff participating in the Test for Tots program. It's for unvaccinated children ages 2 to 5 years and staff who are not fully vaccinated and boosted. You will have a stock of antigen test kits on hand, and you can reorder when 50% of your stock has been given to participants. The reorder process is still under development, but CDD will be communicating that once they have that up and running. There are letters that can be found on the CDD page that explain the purpose of the program to the families. And there are videos on both the CDD webpage and Department of Health webpage on administering and reading the test. There's no specific training needed as far as how to do the tests, but those can provide some good guidance. And we also will be following up with an email, and in that email, we will have some information, some tips for swabbing kids that you can provide to families if they're having trouble with that. So what will happen is the testing protocol will be initiated when participants are either identified as a close contact or become symptomatic while at the program. So if you are notified that someone attended the childcare while infectious, you're going to contact trace within your program. Close contacts can finish the day as normal. There's no need to send anyone home. Everyone participating will get tests for up to 5 days since the initial exposure. Families will need to test their children prior to bringing them to the program, and staff members will test themselves prior to arriving to work. When families drop off their children, we encourage you to follow up with families on the test results, but we are saying that you should not be requiring proof of the test to enter the program. And the rationale is that it's very difficult to prove a negative test, especially when it's done elsewhere, as the tests don't hold the results. CDD did create a parent tracker that parents can use and show at drop-off, but regardless of how you choose to track the test results, programs and parents just should really be communicating about what's happening for the testing. And everyone will need to wear a mask indoors except when eating and napping. I know this becomes the sticky point because of, like Katie said, the inconsistency with napping and with masking, sorry. And it's been decided that inconsistency with masking does not mean that children ages 2 to 5 are excluded. We just encourage them to do the best that they can. And when they are not at the childcare, they will still need to be quarantining at home.
And I'm going to talk a little bit more about the age 6 weeks to 23-month little people. So close contacts will need to stay home and quarantine in this age group. If children are not close contacts, they may go to childcare if the childcare program has the ability to keep them isolated from the other children in the program who are close contacts. If they are not able to do this, then the 6 weeks to 23-monthers should not attend the program. Close contacts who had a confirmed case of COVID-19 within 90 days or are fully protected, again, fully protected, meaning adults that are vaccinated and have received their booster shots when they're eligible, and children age 5 and up, their primary series was completed within at least 2 weeks prior, must wear a mask around other people while in the childcare program for the next 10 days. Individuals enrolled in the program who are symptomatic with COVID-19 symptoms. Okay, so when a child or staff member becomes symptomatic while at the program, they must leave as soon as possible and should be provided with antigen kits to take home. A child who is symptomatic and did not attend the program that day should also be contacted and encouraged to pick up antigen take-home test kits if they are enrolled in Test for Tots. If the test results are negative, the individual may return to the childcare program once symptoms are improved and they have been without a fever or fever-reducing medicine for 24 hours, and they have had negative test results on 2 antigen take-home tests as close to 24 hours apart as possible. If a child has any symptoms of illness, they must also follow the child care licensing regulations. We may not be dealing with COVID in this situation. It could be the flu or other contagious illnesses. So we're really encouraging that children should not be in care if symptomatic. If they are not symptomatic and meet the new criteria, they can return to care. If the antigen test result is positive, then that individual should stay home and follow the Department of Health guidance.
All right, so we're going to move into the questions that were pre-submitted. So thank you for sending those in. And we just want to start by saying, again, we had a lot of questions come in, and we'll do our very best to get through everything and hopefully be able to answer your live questions. But anything we don't get to, we will get those answers back to Brenda to get out to all of you. And we also just wanted to start by saying we had a number of questions that were submitted prior to the Test for Tots guidelines being released. So we did our best to incorporate those into the review of the program. If we didn't specifically go over that in the review of the program, we'll review them now. So our first question is asking if Vermont's youngest citizens with disabilities can get the Test to Stay kits available to the public. And so if your program is participating in Test for Tots and a family consents to doing Test for Tots, that family will get test kits regardless of disability. Additional, the federal free at-home COVID test program is a really nice, easy way that families can order some free kits, and I'll put the link for that in the box.
And I also wanted to just say that the pediatricians and Allison to jump in whenever they feel like they will have something to add here. Just feel free to interrupt because I have my screen on minimized, so just jump in. Okay, so the next question is, what documentation does the CDD need to determine if programs are following the outline of Test for Tots? There are no reporting requirements related to Test for Tots. Programs can develop their own monitoring and tracking systems for program implementation if they would like.
Will you provide the consent forms? So the CDD has sample letters for families on their website, and these letters explain the purpose and process of the program. The letters could be used as part of the consent forms, but a universal consent form has not been provided at this time.
Okay, so there were several questions about Test for Tots and childcare and whether it would be appropriate. So one of the examples is it sounds like the underage 2 children would be unable to attend FCCHs as generally there's only one teacher. This would be tricky as I would not be able to let the 1-year-old attend if some children are doing Test to Stay, correct? How would this work equitably? How can I determine who gets to attend? So, I mean, I think we've said this already, and it's really important to remember that this is a voluntary program and it may not be the right fit for each childcare program. In this particular situation, from above, the provider is right. If you're unable to isolate children under age 2, they would have to be kept home if there was a close contact and others were participating in Test for Tots. If a program was not participating in Test for Tots, however, it's likely that all the children have to stay home in this situation, not just those under age 2. This is not an easy decision to make, whether you participate in the program, and there's no right answer to this, but it is another option to ensure that more children are able to attend care.
All right. The next question asked, when will vaccinated teachers who are often not insured have access to antigen tests? What about vaccinated children? So as rapid antigen tests become more accessible, the program may be updated to make rapid antigen tests available to vaccinated staff and children identified as close contacts. Please note that the staff who have completed their primary vaccine series but have not received their booster may still participate. And we just want to again remind you that this program was created in collaboration with Vermont Department of Health, and we are
don't think I was supposed to be, so I'm getting off. Bye.
that this was created with support from Vermont Department of Health, and that we support that staff who are fully protected, meaning primary series and booster, do not need to quarantine or participate in testing when identified as a close contact.
Can we provide testing kits to vaccinated individuals to test on just day 5 after exposure? Are we providing testing kits for all household members if someone within the household tests positive? As of right now, again, keep up with the changes because things may change. Test kits are only being provided to unvaccinated children and not fully protected adults, meaning not fully vaccinated and boosted if eligible. Tests cannot be given to vaccinated children on day 5 after exposure. Testing kits are only provided for the children in the program, not household members, even if there's a household exposure. So just remember, keep checking the website because things may change.
Are close contacts in this program only those that occur directly in the program, or are people able to participate after community close contacts? So community exposures are included in this program. So regardless of where the exposure happened, if they elect to, they can participate in Test for Tots.
Why does the VDH guidance we receive on the phone differ from the Test for Tots program? So this is a kind of a tricky question to answer because I don't know what this individual was experiencing. So, I would need further information to identify like exactly what's happening in this specific reference, but just another plug for remembering, contact us and let us know when you receive different recommendations, or if you have questions about the recommendations, that information is really helpful for us. So, and I also want to remind people that Test for Tots is a way to keep children in childcare when they would otherwise need to be at home quarantining. So that's their goal. The Department of Health, meanwhile, is giving out standard information on quarantine guidance, but sometimes they may not be taking into account how that guidance changes with the Test for Tots participation. So keep asking questions.
Can antigen tests still be used with Omicron? Yep, the FDA is still saying to use the antigen test as ordered.
And how accurate is antigen test? So although the CDC recognizes that the sensitivity of the antigen test varies, they are most accurate when the individual is contagious and when there's widespread community outbreak. So according to the CDC website, false positive results are unlikely when antigen test is used according to the manufacturer's instructions. And a false positive result will occur, especially in communities when the prevalence of infection is low. So in general, for all diagnostic tests, the lower the prevalence of infection in the community, the higher the proportion of false positive test results. So they are less likely to have false positives during widespread community outbreak, which is what we are experiencing right now. And we will put a link to that resource in the chat as well. And I don't know if somebody else wants to jump in on this or.
All right.
I think one of the other questions is really actually the false negative, right? Is probably what people are really wondering and concerned about. So sequential testing improves, that piece, that worry about missing a case, which is why in the various guidelines, the recommendations, oftentimes either if you're close contact or you have symptoms with the antigen test, we do want generally multiple tests. Whereas a PCR test, which are still available, still wonderful tests, they will pick up to the genetic material from the virus. And so it will actually oftentimes be positive first. And that is a very accurate test. That is a test though that can remain positive for quite a period of time, even after you're no longer infectious. So the antigen test I think about as being the test that can really identify when you're most infectious. So, right, like if you've got a close contact and you test right away once with an antigen test, we still got to keep testing. That's why the guidelines have repeat testing, because you want to pick up at the time that you're most infectious. And especially during a period where there's so much Omicron, we really want to figure out when people are most infectious and have them isolate. So the antigen test can work really well, in really finding out that goal. Whereas if you're symptomatic and you just take one antigen test, we don't think that's good enough to say for sure you don't have COVID. You need to either take a PCR or do another one.
And that leads perfectly into the next question, which Becca, thank you for answering that for me, but it was the question of why would we use antigen test versus PCR? And like Becca's saying, the PCRs are more sensitive, but they're also going to be showing up as positive after a COVID test for a longer period of time. Whereas the antigen tests are going to tell us more about the here and now, are you currently infectious and able to transmit the virus to others? And so when we're looking at Test for Tots, we are trying to get the real-time information so that kids can go into the childcare, but saying, okay, not have you had it in the past 90 days, we're saying, do you currently have infectious COVID-19 and could transmit it to others, which is why we use it.
Are rapid tests now recommended for use on under 2 years old? No. Antigen tests have not been authorized for use in children under the age of 2. Children in this age group can use the PCR test, which generally takes 1 to 3 days to get a result, or a LAMP test, which generally takes about 20 minutes to get a result, but are not widely available yet.
All right. Can you get COVID more than once in a short amount of time? Should you test before 90 days after a COVID positive case? So getting COVID more than once in a short amount of time is possible, but not probable. If you do have new onset symptoms, which could be related to COVID, and it's within 90 days of a previous infection, you should speak with your medical provider about if a test is warranted. In general, if you're testing within 90 days, a PCR would likely still show positive from a previous infection. So you would want to have the antigen test. And like we were saying before, you want to do it a couple days in a row. You don't want to just take one and consider that done.
We are seeing infections within 90 days. So unlike with just Delta and Alpha, where we didn't really, we are now. So if you're symptomatic, I do think you should check in with your provider about whether they want you to test or there's another reason for your illness, because there could be another reason. You could have strep throat or a cold or anything else. But I do think it's important to check in with your provider to determine if you should test again.
Okay, we had a next question about the KN95. So how long can a KN95 mask be used? These are the new gold standards for everyone and are costly. So there's not a single right answer for this question. While KN95 masks are not washable, with proper care, your mask should be reusable for an extended period of time. So you can use your mask as long as it's comfortable to breathe and is not soiled. When it becomes uncomfortable to breathe or gets visibly soiled, should throw it away. It's just in a normal trash can. It's advisable to have several KN95 masks to be able to accommodate storage time between use. So best practice is to keep your mask clean between uses and store your mask in a paper bag for 48 hours before wearing again. So then you get that. That's why you need several to kind of keep them in rotation. And you can wear a plastic face shield to prevent your mask from being soiled as well.
The test for TOTS requires children to remain masked while in childcare. How is this implemented when children unmask to eat together and do not wear masks at nap time? So the guidelines state that children and staff who are testing daily must wear masks while indoors except when eating or napping. So it's okay that they're unmasked during these activities. And like we said, for this age group, we want them to do the best they can.
So this next question may be a little bit of repetition, but we really had a lot of questions on it. So we're going to read this question. So we've had questions around masking for children, especially with the new VDH quarantine isolation guidance, specifically referencing masking. So in the test for TOTS FAQs, the CDD stated, "We understand it's difficult for young children to strictly adhere to wearing masks throughout the day. Children ages 2 to 5 who cannot consistently mask can still participate in tests for TOTS. We know it can be confusing, so many changes happening all at once, but we also want to reassure you that the test for TOTS program is made based on recommendations from the Department of Health and our epidemiology team, and we are in agreement with the program guidelines. And we know that the VDH website suggests masking around others through day 10, but the developmental ability of children ages 2 to 5 years old and their ability to mask consistently also need to be taken into consideration with these guidelines."
I just pipe in for a sec. Hi, everyone. Rena here. I just want to acknowledge that these aren't inconsistencies, even though they sound like they are. And the gift of having pediatricians, public health employees, the child development division team, all here together is to show you that we've made such careful consideration and we understand what the science behind this is, but also where we have to acknowledge child development. So if a child has a negative antigen test in the morning, that's an extremely reassuring sign that he or she will not be infectious enough to transmit that virus just that day. So if the mask wearing is inconsistent and comes in and out, that's okay, because you have the negative test from 4 hours ago, 6 hours ago, and then the child goes home. And then the next day you get the reassurance of a negative antigen test again. So I think what's so hard, and I'm so grateful for all these teams and all of you, is just putting the information together into our brains in a way that allows us to move forward. And even the questions a few minutes ago about antigen PCR, like I came on with you probably 5 times in 2020 and said, antigen tests have no place here. I really want to acknowledge that. We had low prevalence in our communities, and we wanted PCR gold standard for all. So if you're having that shift into antigen tests are good, where I understand and I'm with you, and we've all been making that shift for several months, but it's based on the prevalence of the virus in our communities and the fact that it detects your contagion / infectiousness real time. So I'll stop there, but I can feel it's not inconsistent, it just feels like it is. And we really know, you've taught us about child development in this space, because as we all know, children are actually, they're doing better with masking than we ever expected from those early days, but there's also tons of variability. So thanks for all that.
I think also I would just add that you can look at masking, much like Brina said with the testing. It's like that analogy that we always use, the Swiss cheese approach, right? So like all together it has holes, but when you put several slices together, some of those holes are covered. So the antigen test is one piece of the mitigation. Masking, even inconsistently, still adds another piece of the mitigation. You know, all of the things you do at school for hand washing and all that other kind of stuff adds another piece. So I think it's about all the things you're doing collectively that decrease it. So even when masking can't happen every second of the day, it's not that, oh, well, it must not really matter because I can only do it for 3 hours of the day, not 8. I think it's just look at it as like the Swiss cheese thing, right? Like every layer you can put in helps. And when it can't, you have those other layers like the antigen test to be your backup.
All right. Thank you both for that. Allison, I hadn't heard the Swiss cheese analogy, but I like it. It makes sense. So the next question has a couple different parts. So it said, we need better guidance about kids too young to vaccinate or mask, and clearer information about whether antigen tests are of any use if the kid has symptoms, and what to do with little ones who sniffle all winter long but cannot be excluded for care for 6 months entirely. So if a kid has symptoms, antigen tests are helpful to determine if the symptoms are COVID related. But like we've said, it needs to be done at least 2 days in a row, 24 hours apart, to get the best accuracy and safety with that. If they have been cleared when it comes to the sniffles, if you've cleared them for COVID and they're having the sniffle still, we're looking at new onset or worsening symptoms. So we want to be looking for sudden changes, full facial crust, increased needs for wiping, lethargy, things that are new and different, which would be cause for exclusion. If a child has new symptoms but hasn't been identified as a close contact, they can return if symptoms resolve within 24 hours or with either 1 negative PCR or LAMP test or 2 negative antigen tests, and marked improvement in symptoms for 24 hours, meaning no fever, acting well, eating, drinking, playing, as well as lessening of secretions, coughing resolved, etc. And it's important to remember that if the child is under the age of 2, they cannot use antigen tests. It must be a PCR or LAMP test.
Okay, can more specific guidance be provided about what part of the child care licensing regulations this phrase is referring to? This is the current infectious disease protocol in the child care licensing regulations. This phrase appears on the tests for TOTS information page under the section about staff and children with symptoms. So the link in the program design brings you to the child care regulations webpage. You click on the center-based regulations, and it should take you to Appendix A, signs and symptoms of illness chart. You might have to scroll up or down to find it. You should be following the directions on the chart for specific symptoms that the child is displaying. Children should not attend care if they have symptoms of illness, even if they have had a negative take-home antigen test or PCR test. We're really trying to reinforce that information with parents as well. Just keeping children home when sick, it's really important.
And we had multiple questions about the testing protocol and safety and safety in Test for Tots. And so again, this goes back to the antigen test showing us in real time if a child is currently infectious. And by doing it multiple days in a row, we make sure that we cover our bases and that that we're not missing their infectious period. Omicron has a shorter incubation period, as we said earlier. So if someone's infected after a close contact, we're expecting to see that show up as a positive within those first 5 days, which is why that's the 5-day protocol.
My local school just sent out a letter to parents on January 18th saying they will no longer test to stay. If a child shows up to school with any symptoms, they will be sent home with a test that parents administer. What does this look like for providers when a child directly goes to and from school from a childcare business? Since the Test for Tots program just rolled out, our program is going to follow these guidelines also. So just looking at this question, I think the important thing to really note here is that this is a child with symptoms that they're talking about here. So this child experiencing symptoms shouldn't be attending school or childcare, and they should be staying home or going home. So they shouldn't even come to your childcare from school if they've had symptoms. They should be going home.
All right, so the next one is a scenario question. So the scenario is a child was with parent number 1 from Sunday to Wednesday. Parent number 1 went to the doctor and had a COVID test done and it was positive. Child's last day of exposure is Wednesday. Parent number 2 did an at-home test on Thursday and was negative. Child had a PCR test on Friday. Result came back on Monday and it's positive for COVID. Child started showing mild symptoms, cough, on Saturday. Child continues to be mildly symptomatic. When is the child able to return to childcare? It's a doozy of a question. It's a lot of moving parts and it's understandable why it's so confusing. So we tried to think about our thought, try and put into words our thought process with this one. So in general, you would say the PCR test was done on Friday. That would mean Friday is day 0. However, in this case, because the symptoms started after the test, day 0 resets to symptom onset. So that would mean that Saturday is the new day 0. So they need to isolate at home for 5 days, with day 0 being Saturday. So that would make day 5 Thursday. The isolation guidance says that they could leave isolation after day 5, meaning on Friday, if the following conditions are met. Their symptoms need to be improved and the child needs to be feeling better. No fever for 24 hours without the use of fever-reducing medicine. They wear a mask around others through day 10. Again, recognizing that with the 2 to 5-year-olds, we do the best we can with masking. And we're strongly suggesting that they have 2 negative antigen tests performed at least 24 hours apart, beginning no earlier than day 4. This is not a requirement, but it really is best practice, and we really encourage people to follow that guidance.
I think that scenario illustrates how hard this all is. So the next question is about long COVID. So what about long COVID? Are we ignoring that risk? Department of Health is certainly aware and not ignoring the risk of long COVID. We're still working hard to prevent COVID infections in our community and with mitigation strategies. And the other thing to note is that, especially with the Omicron variant, it emerged in November. So we really even haven't had enough time to know what long COVID looks like.
The next question asks, are we prioritizing the economy or the well-being of Vermont's youngest citizens? So we understand the changes in the guidance they're big changes, and it can be overwhelming and scary and feel like it came out of nowhere. But we want to provide reassurance that the state, in consultation with our infectious disease pediatric advisory team, is working hard to really consider all aspects of this and make sure that everybody's safety is considered and protected. And kind of what we reviewed with the quarantine and isolation guidance is the incubation and infectious periods are shorter. And that's why the quarantine and isolation periods are shorter. It has to do with those periods, not the economy.
I can jump in and add a little bit here. So you all know this better than anyone. So I think parents of young kids, pediatricians, and childcare providers know, like, especially in the winter, there is so much illness that goes around all the time, right? So in the pediatric ICU here, I spend, pre-pandemic, I spend my winters, especially December, January, February, March, April, even May, putting kids on ventilators for respiratory syncytial virus or RSV, influenza, metapneumovirus, parainfluenza, rhinovirus. And so we are used to, in this age group, especially younger kids, getting pretty sick from these viruses. What we are noticing is that the children that we're admitting who have COVID what we're seeing is something very similar to what we see with other viruses, although they're not getting that lower, younger children are not getting that lower kind of pneumonia bronchiolitis picture that RSV gives them. And currently I'll share with you that I actually haven't seen a case of RSV in 2 weeks. And there's some great data from England showing pediatric hospitalizations where, although COVID, they've kind of gone through their Omicron a bit before us. Their COVID hospitalizations, although the highest it's been in the pandemic, it's a tiny fraction of what they see every winter for RSV hospitalizations. So I think it's important to put into context, what kind of illness we typically see among this population, how sick these kids can get, and what sort of mitigation measures we typically use, pre-COVID, which is try to, stay home when you're sick, which I know from your vantage point is always hard to do. And I hopefully, going forward, families will continue to we'll all be better at staying home when we're sick and keeping our kids home when they're sick. So I really do think that, that what we're seeing in terms of hospitalizations, at the moment, we're having fewer pediatric hospitalizations than we normally do in January in Vermont, because normally we have a ton of RSV and we're not really seeing that right now. So, you're all used to seeing a lot of viral illness, and this is another really, another virus that can cause severe disease in kids, but generally doesn't. So we're really not seeing huge peaks in pediatric hospitalizations like we do during RSV typically. Just so you all know what the context here.
So we did have one more question, which I feel like we've answered multiple times in this. So I thought maybe the last few minutes might be a good time to devote to some of the questions that we've been seeing in the chat. There's a lot of them. And so just so people know, we will answer your questions and we'll submit the answers to Let's Grow Kids so they can send them out if we are not able to get your answer in this hour, because we have 6 minutes left.
And for people who pre-submitted questions as well, I just want to acknowledge there are a couple questions that we're still hunting down the answers for. So if you didn't hear your question, there's a couple that we're still very specific and we're still kind of searching for the answer, and that will be included in our other responses.
Yeah, so folks, full disclosure here, I've been starting to provide written answers to your questions, and it's for the sake of time. So I think maybe if you did put a question in early in the hour, if you wanted to go back in the Q&A and look under answer, I did some typing, but that might not be as helpful now that we're up at 35 more. But why don't we just start? And this is kind of a role I play in other webinars, so I'll just start reading them out and maybe ask people to chime in if I don't know the answer, I think, for the 5 minutes. So Andrea wants to know if Delta variant's done. How can we know if an individual tests positive for COVID that they have Omicron and that it's okay to leave day 5? Andrea, yes, that it's somewhere in the high, not like 97, 98% of all cases are Omicron at this point, which is why the policy change is sound. Emily wants to know, how does this keep childcare providers and staff safe from getting COVID? Isn't it possible that a child could test negative day 1 and 2 by antigen and then test positive day 3? If so, would the other children become close contacts again? Emily, yes, that is possible, but the exposure would be the day of the positive test. So it would just be, I'm not sure how people are setting up the morning, but the other children would be identified close contacts, and yes, it would have to start the clock all over again, and it would be a math equation. But those days the child was negative are the reassuring days for contagion. Anyone else want to take that one?
No, that's what the schools were doing too. So yes, so sometimes the clock does need to get restarted. And there were a few questions asking this, so I'm glad we got to it.
Claire wants to know, after day 5, if symptoms are resolved, but the child's still rapid testing positive, can they return? So the answer is no. You have to have 2 negative antigens at least 24 hours apart to return. But we will add the caveat that all people day 10 can return after COVID. And so we don't recommend antigen testing like day 8 and day 9, because if those tests are positive after that point, they're still not infectious, and we feel very comfortable with the timeline of those children returning. So there is this kind of rolling piece after day 5 of wanting the antigen to be negative, but when you get out to day 8, just stop antigen testing, because that person is getting well and not contagious. Okay, what if a program and its families are more comfortable having close contacts go home and return after 2 antigen tests instead of 1? Don't think I understand that question. Does anyone? Yeah, I need clarity on that
So,
one. And go ahead.
I could be answering this wrong, but I think, people have different comfort levels. Some people will not want close contacts in their program at all. They want them to do the quarantine and wait until the end of the quarantine. And people have different comfort levels, and that's okay. The thing to remember is that if you are participating in Test for Tots, you have to follow the guidelines as they're laid out. So if you're not comfortable with having close contacts, stay for the remainder of the day and return the next morning after just, each morning having 1 test. That's okay. It just is a sign that it's probably not the right program for you.
Can I just add one commentary, and that is, and Allison can back me up here too, but when we think about different types of exposures and close contacts, I really think about it as like 3 different types of close contact exposures. There's the school or childcare based exposure. There's the community based exposure, which could be like you go over to a friend's house and have lunch or dinner or a birthday party, something like that. And then there's a household exposure. And that's actually the order of risk of transmission. So the school or childcare exposure is we know, we have data on this, that's the least likely to end up with a transmission. And then community is a little bit is more risky. And then because we're more informal and masks are down and eating and drinking and closer contact, and then household exposure. And so when we're thinking about, it's like overwhelming to think about how much Omicron there is. And sometimes we're focusing on the cases that we know about and the exposures that we know about and getting really focused on that and not realizing that people are out and about not knowing what other types of, potentially not knowing what other types of exposures. And we're really relying on families to tell us, in your case, to say like, there's a household exposure, there's a community exposure. So I think just keeping that in mind too, is that there's a lot of exposure happening out in the communities. And we know if anything that the, exposures that happen in these types of settings tend to transmit less. So that can help sort of reframes how we're just kind of thinking about this a little bit too.
Thank you for that. And I wish that I didn't have to wrap it here. We do need to wrap. So I just want to say many thanks and deep appreciation to each of you for joining today's conversation. We can always count on this group of public health professionals to affirm our work with young children and their families and give us a healthy dose of common sense for implementing the guidance and best health practices in our programs. As always, a recording of this conversation will live on the Let's Grow Kids website, along with answers to the questions that weren't answered live today. And as the nurses said, the ones that they didn't, that they're still working on the answers. So with that, we're going to wrap it up. We will get together again. We don't have a date set for that yet, but I wish you all a beautiful afternoon.
Thank you.
Thank you for having us.
Thank you.
Our
Thanks,
pleasure. Thank
everyone.
you.